This week on the BackTable podcast.
When we are considering urology, we have always to consider that is a techno-driven specialty. We always been in forefront of embracing new technologies. I was saying from laser to robotic surgery to everything basically. So now AI could potentially be the perfect ally. It can be the perfect way for decreasing our workload, keeping the workflow, leverage everything to the highest performance as possible.
Hello, everyone, and welcome back to the BackTable podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guest today, Giovanni Cacciamani from USC Keck School of Medicine, where he's an assistant professor and director of the AI program. Gio, thanks so much for coming on. How are you doing today?
Thank you, Aditya, for having me here. And I'm so excited of being here today talking about AI.
You know, it's pretty cool as a host of this podcast. It's cool to see one of the meteorically rising stars in our field, in such a new field such as AI. And I'm just thrilled to pick your brain today, Gio. And maybe I'll share a little anecdote before we jump in. There's these things in the course of our lives in recent history, blockchain, machine ledgers, AI, have typically kind of been abstract concepts to me. And then one day, a colleague of mine, Tyler Stewart, called me in his office and said, "Hey, man, I want to show you something." And he logged on to Chat GPT. It took about 7 seconds using his Google email. And he said, "Hey, I'm planning a dinner party for 5 of my urology colleagues. Help me put together a 5-course meal with drinks." And the output just completely blew my mind. It was prostate punch made of X, Y, and Z, and you're in luck lamb chops. And we went through 5 or 6 of these things. And I just went home to my wife. I was like, "Mona, I think the world is going to change like yesterday." So it's getting here. It's becoming accessible. And you've really been on the forefront for a while now. And I thought we could just maybe start out with some basic definitions. AI, let's just kick it off with that.
That's an excellent point. So one of the things that we have to consider first is that AI is not a real new thing. So the story of AI started over 72 years ago when Alan Turing basically wrote one of the first publication on AI. And the title of the manuscript is The Imitation Game. And I'm pretty sure that, a lot of people that are listening to this podcast watched a couple of years ago the Imitation Game movie. And in that movie, which is a biographical movie, they talk about the story of Alan Turing and how basically he discovered AI. He basically was in the forefront of making basically the Second World War ending. And he discovered a way for decoding the Enigma machine that was used by the Nazis for, writing the encrypted messages. And he found out a way for decrypting those things. And over the last 72 years, actually, we have witnessed to the rise of artificial intelligence and the entire technology around computer-machine technology. Regarding the definitions, definitions are, in my opinion, are too narrow sometimes. And, I find myself teaching to our residents, to our fellow, to try to find out a way for making those definitions more digestible. And I was literally playing with some games with one of my nephew. He's 5 years old, young and bright guy. And I was trying to figure it out a way for making those definitions more digestible. At the end of the day, we are physicians, we are urologists. And sometimes we lack on how to understand the behind the scene of all these type of definitions. So let me just give a couple of definitions, the way that I used to give to my residents. So when we are talking about AI, in general AI, we have to define AI as the theory and the development of a computer system able to perform a task. And normally those tasks are requiring human intelligence, right? So one of the things that I used to say to my nephew is that let's try to rephrase and try to make more digestible these definitions. So what is AI? So imagine, like, for example, you have your toy robot like Optimus Prime. And imagine if your Optimus Prime could think and act like a person. Well, AI is like teaching computers to think and do things that people do. like talking, seeing, and making choices. And within this artificial intelligence, which is like an entire world, you can have machine learning, deep learning, and of course, what you were mentioning a few minutes ago about ChatGPT or generative AI. So for machine learning, technically, is like a subset of AI that allows system to automatically learn and improve from experience. And if we have to do the same thing and trying to teach to our toddlers, to our kids, what is machine learning, we can say that machine learning is like teaching to Optimus Prime new tricks and it's going to learn it by itself. If you show to Optimus Prime, for example, what to do many times, it can figure it out how to do these tricks on its own. Going down and going a little bit deeper, you have deep learning. And technically speaking, deep learning is like a subset of machine learning that is employing a neural network for with trees and more layers to simulate basically how we think, like the human brain, and to learn from a large amount of data. This is the main thing. So machine learning is a way to improve by experience. Deep learning is basically learn from a large amount of data. Going back to, my nephew. So when I say, okay, let's try to figure it out a way for digesting this information. So deep learning is just a special way of teaching to like Optimus Prime, your toy robot. It's like building a robot brain with many layers. And each level helps the robot to learn things better. And then on top of these, inside this deep learning, you have the generative AI, which is actually what you were talking before, and which exploded November 6th when OpenAI released out of the blue the ChatGPT. So generative AI are algorithms that use data to create new content similar to the content that you are using for training this data. And again, if you have to think of digesting this information for a kid, you can say that imagine that you have a magical coloring book that could draw pictures by itself. And generative AI is basically like that. It's like that magic coloring book making you pictures and look like once it saw.
I love that. And so like over the course of our lifetime, we started hearing about machines, Deep Blue beating Gary Kasparov in chess. So I kind of think of that as your maybe early machine learning. You plug in all of these possible different openings and closings, and then Deep Blue can sort it out. And then maybe the next iteration is you tell the machine, here's the rules to chess. You figure out all the permutations, and then you get a superpower. And maybe generative AI would be, can you come up with a game that is as scintillating and timeless as chess, that is digestible yet complex enough for humans to enjoy and understand? Is this okay?
Well, okay. So if you're asking me if is that okay, I would say, nee. So in other words, what we have to consider is that this kind of technology is, extremely satisfying. Let's put it this way, for train. But on the other side, it is extremely and also helpful for us as physicians, for example, for understanding how we can make the things better, reducing our workload, keeping the workflow. On the other side, we need to, keep in mind that those machines are not able to think by themselves. Even though the chances that we actually can feel that those machines, generative AI, could potentially generate new contents, actually they are regenerating contents, which actually is a little bit different. The main concept, the concept of chatbots in general. So the way that ChatGPT is generating the output, with this cursor that is, progressing as somebody's writing, is just to make the human touch, the human feeling. But at the end of the day, are not human at all.
No, I definitely appreciate that. And maybe the other word that has come across in my preparation for this episode is LLM, large language models. Can you just talk a bit about that, Gio, and how that fits in with what you just described?
Yeah. Large language models, such as, for example, generative pre-trained model that is GPT 3.5 or 4, are a subtype of generative AI that allows you to generate output from different and if is defined like that, is basically a normal AI. However, the input that you can use for generating a new output can be images, videos, text, and you can generate from those videos, images, or text. That's the main thing about generative AI. Again, when I'm saying that generative AI the term generative could potentially be misleading. As humans, actually, we are generating something because we process the world that is surrounding us to create new contents. That is the real human touch. Generative AI right now is able to elaborate the input and then generating something based on the input. So without thinking by itself. When at some point, generative AI will start making output by itself, we will have another BackTable meeting and we will discuss about that a little bit deeper.
Yeah, I mean, every conversation I have with people that think about this, it blows my mind over and over again. So before we jump into it, AI and medicine and urology and surgery and so forth, tell us a little bit about how your interest in AI was piqued, how you developed expertise and kind of got where you are today.
Well, okay. So first and first, let me tell you that even though it's appreciable being labeled as an expert, I can tell you that especially in AI, the field is evolving so fast that nobody is a real expert. What actually I'm doing, I'm enjoying the journey through expertise, which actually is something that has to be taken into consideration. The field is evolving so fast. It's called also exponential medicine. That is basically impossible to define experts in this particular field. You can have basically people that are passionate on that and trying to make their contribution in the field, but being an expert is very, very tough. So, my background, I'm a physician, I'm a urologist, and I started basically being interested in AI 3 or 4 years ago when here at the USC, we started a journey for implementing the use of artificial intelligence, specifically green learning, to predict the pathology from the radiology. At that point, the pandemic hit the entire world, and I have basically to find out a way for using my free time. And, when I figured out that my fellows were extremely, I would say too busy, I say, okay, let me find out something different. And I start studying a little bit about AI. And I come across the book that is a bestseller book by Eric Topol, Deep Medicine. And on the cover of the book, you can say how AI could potentially make medicine human again. And that particular thing actually, blew my mind because we are living in a world where we are working 12, 15 hours per day. And the majority of the tasks, even as physicians, as surgeons, are always the same. And that's basically one of the main reasons of the burnout. One of the very recent survey on burnout showed that in the US, 64% of physicians are in burnout. And 53% of the residents are in burnout as well. So you are actually being in burnout even before literally starting being a board certified urologist. And the majority of the times burnout is related to the repetitive task that we find ourselves do every day. AI actually could potentially be the perfect ally. It can decrease the workload, keeping the workload on the highest level as possible. And then I started thinking, okay, let's figure it out how we can test from an academic perspective and see if we can then bring from the academic perspective into the clinical practice. And we started this journey. And right now, in 2022, thanks to my chair, Dr. Gil, we established the first artificial intelligence center in urology in the country. And right now we are starting having some fellows that are coming, residents and other faculties that are, join me, like Andrea Bru, who is an expert in image-guided technology, and Mitchell Goldenberg, who is a real expert in surgical AI.
I love that. So I'll share another little story. At the AUA Leadership Retreat, which was just a week ago, one of the projects that we had proposed were creating templates, say, for instance, the microhematuria guidelines that allow it to be fairly user-friendly for a provider to make sure they've checked all the boxes in terms of number of red cells, smoking history, risk factors, et cetera, put them into buckets and dictate next steps. And we were just kind of discussing this at a table, and a colleague there mentioned virtual scribes. These are going to be coming from the Philippines, India, and so forth, that could scribe. And then it evolved into, what if you could just literally log in your phone, set it there, and at the conclusion of your visit, you have a AI virtual scribe that can put together a right note plus the billing. So when you walk out of the patient's room, everything's kind of there. And even better yet, maybe collate all of the preparatory H&P, consult notes, labs, imaging, and provide you with a near comprehensive synopsis of all the information that you would need to counsel that patient based on their chief complaint, for instance. And it was just such a mind-blowing thing. Like, imagine if the time spent could be with the patient and making sure that they understand things. So, and what that would do in terms of burnout isn't tremendous. David Keynes with Well Prepped, I think what he's done in terms of creating content for patients is amazing. So I appreciate you sharing that story. And, it is amazing how a little bit of free time and a little bit of direction can open up a world of possibilities. So this has got to be a little bit of a tough one because it is so all enveloping and encompassing. Maybe just an overview of the use of AI in medicine and urology. And I'll just try to keep it somewhat digestible. Pick your top 3. These are how the game's going to change in the next years.
That's is something that is extremely important because we need to make practical AI for practicing urologists. So we need really to start going from academia to the real practical usage of these artificial intelligence extensions as it should be. So first thing first, we need to figure it that we need to start saying that nobody's going to replace our job for now. AI could potentially be the perfect co-pilot for improving our experience in medicine. So let me give you a couple of examples. We know that, all of us see in clinics patients that are coming with a multiparametric MRI. Best scenario for us, not for the patient, is that the multiparametric MRI is telling you there is a lesion. Because of the lesion, you're going to do a biopsy, a target biopsy, and the target biopsy could come back with a cancer or not. We know that the way that the MRIs are, read is depending on the radiologist experience and also on how and when the radiologist actually read the MRI. There are some papers that are saying that when a radiologist is evaluating the MRI, the birthday, actually the performance is lower. So machine AI could potentially be the perfect co-pilot for a radiologist, for example, to finding a region of interest automatically. It can spare time in telling you, okay, hey, there is a lesion there, and the system could potentially also start making the segmentation of the lesion. And after that, the system automatically can give you the prediction of what is the pirates and what could potentially be the pathology. So imagine to export this kind of framework millions of times in our daily practice. And imagine how much time we could potentially spare in reading MRIs with an higher accuracy. So that is, for example, one of the possible usage of artificial intelligence, which is the enhanced imaging vision, which is one of the most attractive field in the use of AI. Another thing, for example, could be that we have some patients with a bladder cancer, and before the surgery, if they are suitable, we can administer them a neoadjuvant chemotherapy. Sometimes, it's very difficult to understand if you have a complete response or a partial response to the chemotherapy. And sometimes you know that after the procedure. Another important point is that sometimes you don't know if you have even a partial response. AI could potentially read through the imaging and tell you if you have a partial response or a complete response to the neoadjuvant chemotherapy. So this is just some example of enhanced imaging technology. Another field that could potentially benefit from AI is electronic medical records and clinical history collection. How many patients we see in clinic? Around 30. And usually 15-20% of them are first patient visit, which means that we need to spend a lot of time talking to them. And imagine you are a patient and you are coming to the hospital, a nurse is handing you a question. Few seconds later, they are telling you, okay, come over. They are coming to the clinic and they are closing the door. Another nurse is asking you the same questions. And after that, the doctor is asking you again the same question, so 3 times. Second thing that you have to consider is that as physicians, we have always, of course, to read through the patient information, preparing ourselves hours in advance. So there is the work outside work that sometimes is not even considered and is not even build. And we are actually spending a lot of time taking out this time from our family or from whatever we want to do. And again, we have some slots in when we are, visit our patients, which are like between 20 to 25 minutes. And it has been estimated that we spend around 20 minutes just filling charts and then just 5 minutes talking to our patients. And we know, all of us, find ourselves, for personal reason, dealing with doctors. When you are on the other side as a patient, You really want these percentages totally inverted. The opposite. You want 20%, 20 minutes talking to your doctor and just 5 minutes in writing patient notes. So imagine in a few years, you have a microphone in your clinic. The microphone is recording like a script, the patient encounter. The AI would be able to identify the voice of the doctor versus the voice of the patient and automatically write the patient note and putting the patient note into context with the labs and with the imaging. This would basically put like to zero the work as I work and making the experience for patient and us as a doctor more enjoyable. At the end of the day, we decided to be doctors, not to fill in charts, but to taking care of our patients.
I love that. And I mean, again, kind of some of the themes that I came across when preparing for this were enhanced diagnostics. You mentioned radiology. I think pathology is another one that's quite prime, where you've got slides that are not stained. You can extract data from them. The predictive ability to dictate whether or not they're going to respond to neoadjuvant chemotherapy or ADT or et cetera. That would be something that I think is extremely profound as well. So enhanced diagnostics as a general field, provider efficiency. You and I both kind of touched on the ability to collate information that allows the provider to be well prepared prior to the engagement and then have much of the documentation and ostensibly the billing in a very highly accurate way done at the conclusion of the visit. So what about early detection? How are things looking in that? That's something we deal with, right? Kidney stones forming, prostate cancer, microscopic hematuria. Obviously, I'm an oncologist, and this is kind of what I spent some time thinking about. Could you maybe give some examples there?
Well, definitely. So early detection is extremely important because that, of course, impact on patient experience and the type of treatment that we use. Let me give you an example. Very recently, last week, Lancet published the first randomized trial comparing mammograms that were done for screening in Sweden from 4 different centers. 80,000 mammograms performed. Randomized trial, 50% underwent just the normal imaging, and the other 50% was a co-piloting imaging or a computer-aided diagnostics, where the AI was indicating to the radiologist if and where there were the lesions. So their main findings was that the AI-assisted imaging was performed at the same way as the radiologist, but they were sparing a lot of time. So this is just an example of how AI in screening or early detection could potentially be used. For example, for prostate cancer, it depends on which variables we're going to take into consideration. For example, over the past years, we are dealing with a lot of nomograms. The good thing about nomograms is that they are technically easy to build, but they are biased by the information that you provide at the very beginning. And maybe there are some information that are not even recorded right now, and because of the quality of the data set that are used, and therefore we cannot be so accurate in the early detection, for example, for prostate cancer. Imagine if we can implement the use of these nomograms that are going to be assisted by the use of AI for detecting the variables, and most importantly, to put them into context with the imaging. Right now, we are surrounded by what we call omics. We have radiomics, we have genomics, we have pathomics. All these omics are basically designing the different variables in the different fields that in the majority of the cases can be put into context with the use of artificial intelligence. But so far, radiomics, pathomics, genomics, they have been evaluated separately. If we really want to bring to the next level and creating what we try to call here the prostatomics, bladderomics, renalomics, is where when you are using artificial intelligence to put into context the different omics, radiomics, pathomics, genomics, etc., all into context with the goal of predicting a given outcome. That will make and bring the early detection and the real early screening to the next level.
I love that. And, it's getting close. You're basically mentioning, next generation personalized medicine. And I was just absolutely amazed at ASCO this year to see a talk given on prostate cancer by some colleagues in radiation oncology where they were able to use, I think it was through Artera, which is a proprietary AI technology looking at the pathology slides, and suffice it to say, predict response to androgen deprivation therapy. And if I'm not mistaken, these are starting to actually get mentioned and brought up in the guidelines we all know, NCCN guidelines. Could you maybe talk just a little bit about that example, Gio?
So our field actually is extremely active in AI. Let me give you an example. Over the past few years, when you're looking at the last AUAs meetings in the last 10 years, the number of abstracts talking about or using or testing any kind of AI technology increased from 13 in 2012 to 87 abstracts last year. And this increase over time, I can expect that the numbers will jump to more than 200 this year. This just for making the point that, as our field has been always in pole position for embracing new technology, from robotic system to lasers, and AI is not an exception. One of the things that we have to consider is that we have to be very careful when we are dealing with the companies that are, proposing their own AI systems without a proper patient-physician level evaluation. I mean, one of the things that we have to consider is that, we are extremely techno-savvy. We are living in 2023, and there are no more excuses for urologists for not considering AI as part of our daily practice. On the other side, academic centers should start thinking of being part of the discussion when engineers, companies are proposing this kind of technology. And we should be in the forefront and the very beginning of the discussion, not when the product is ready, but in the development of the product. And that's why, in my opinion, before having this kind of technology in the guidelines, we should test it very, very carefully.
Yeah, I can appreciate that. And I think as a field, as you mentioned, we're quite active, and it's remarkable. I'm not a AI expert that keeps up with the literature, but you come across a study where the folks at Mayo are taking EKGs from people's iPhone watches, evaluating tens and hundreds of thousands of them, and they're able to predict who's going to have an MI within the next, 6 to 8 months. So it's happening. It's happening fast. So you talked a little bit about enhanced diagnostics. I think we can call that a field. You talked a little bit about, you could say, physician efficiency, and of course, we're surgeons. And maybe talk a little about this. And I'm sure it gets even more complex. Now you're looking at holograms and different types of visualization techniques. But are there any things on the surgery side, either in terms of safer or more effective surgery, that seem to be a ripe fit for AI?
Absolutely. So that is an excellent point. So we are surgeons, and therefore let's add a little bit of wow effect on this talk about AI. So surgical AI is a real thing, and this is powered by the fact that, again, is still an image copilot technology. We are basically living in the minimal invasive surgery, endoscopic surgery. So which means that the majority of our surgeries are video recorded. And therefore, we have a large amount of data to understand basically how we can train machine learning models to, for example, predict some complications or to detect some anatomical variations. So here at the USC, we have a lab on surgical AI. But on top of this, we started a project. The name is Icarus. Icarus stands for Intraoperative Complication Assessment and Reporting with Universal Standards. And a couple of years ago, we basically figured out that intraoperative complications are not well reported. And the main reason why they are not well reported in the literature, is because we don't have the tools for doing that. And as surgeons, we always think that we are basically like Avengers. We don't have any intraoperative adverse events. My past chairman, when I was in residency, was Professor Artibani, who is one of the legends in robotic surgery in Europe. He was used to say that when a surgeon is telling you that he or she has not any intraoperative complication, there are only two reasons: or because he's a liar, or because he's actually not doing any surgery. Intraoperative adverse events, intraoperative complication, near-missed event always happen. The way that you're collecting them is the key. And as surgeons, sometimes we find out ourselves to not knowing how to collect them. And on the other side, we don't have the proper tools for doing that. On top of that, it has been reported that it's very dramatic and tough for a surgeon to admit that an intraoperative adverse event happened. So AI actually could potentially detect the intraoperative adverse events and put them into context with the anatomy of the patient, with the disease characteristics, and with all these things together, actually could potentially, I'm not saying justify, but at least put into context what happened. AI could potentially be used for this. It could potentially be used for detecting anatomical variation, alarming the physician when you are doing something that could potentially lead you to have an intraoperative adverse events. Very recently, our team has just put together a meta-analysis looking at all the studies that were looking at the use of artificial intelligence for detecting intraoperative adverse events. And the meta-analysis of those studies show that artificial intelligence is able to predict an intraoperative adverse event with a 92% of accuracy, which I think is pretty cool.
That's fascinating. And, one of the cool things about being affiliated with the podcast is you meet thought leaders in various fields. And I think it's just going to continue to explode. You're taking all the preoperative variables, you take in the imaging, you create some next generation 3D ability to visualize what you're getting into. And now you can really accurately predict, not some CMS coding nonsense that looks at a comorbidity, what the likelihood is of this person running into a complication. So you can counsel the patients, you can prepare for that. And then intraoperatively, if there's bowel, if there's a blood vessel, if there's a critical piece of viscera, receive an alert. It's quite powerful. So everything that you're describing to me is contingent or sounds to be contingent in some form or fashion on having lots of data, lots of videos, lots of robotic videos, lots of cystos, lots of normal mammograms, you kind of name it, right? And maybe I'll ask for we can run through an example here and I'll tell you a rudimentary project that we worked on and you could maybe describe a ideal scenario in your mind. So one of my areas of interest is testicular cancer, germ cell tumors. I do a lot of post-chemo RPLNDs, and just like everybody else in the world, 40 to 50% of them are fibrosis and necrosis. We've taken sets of patients, 20 with fibrosis and necrosis, the other 20 with teratoma or a small proportion of viable germ cell tumor, tried to do semi-qualitative, are the borders irregular, are the vessels raised, plus texture analysis. And suffice it to say, it's not been that fruitful. Now, I imagine if I had 10,000 negative RPLNDs and 10,000 with teratoma, the ability to impute that would be a bit more usable. So maybe walk me through your ideal creation of a study and how AI is involved to predict pathology on post-chemo RPLND.
That's first and first, that is extremely interesting what you just said, because very recently we have a meeting here at the USC talking about the importance of big data sets, especially for AI. So before I was mentioning that AI is not a new thing. It started 72 years ago with Alan Turing. And the concept and the technology, of course, changed, but the main AI infrastructure didn't change that much. What is changing right now is the quality and how big are those data sets. Quality of the data set and how big is the data set are extremely important for making a machine learning working. And not only for the training, but also for the validation. Let me give you a few examples. Over the past few years, almost 80 publications has been published testing, using, training the use of artificial intelligence for predict the pathology from the MRI in patients with suspicious prostate cancer. The variability on how those machine learning technology were trained or tested is extremely huge. If I'm training a machine learning methodology on my data and you're training your machine learning methodology on your data, my data and your data will never be incomparable because we're not using the same population for testing the performance of those technologies. That's why we really need join the forces as the field and trying to put together big data sets where everybody that has a machine learning technology could potentially test the performance of the technology in the same population. That is the key. Just for these, very recently has been released the PKI challenge. PKI challenge is a prostate cancer challenge. Is a huge data set with more than 10 different centers from Europe that joined the forces and put together 10,000 annotated MRIs with a region of interest or suspicious lesion. And almost 100 groups from all over the world tested their own machine learning methodology for evaluating the performance of their machine learning methodology into the same data set. That is the key. But if I may say, data alone are not sufficient for making an AI framework that could potentially be useful in our daily practice. What is needed, and I learned this on my skin over the last 3 years, is the collaboration between physicians and engineers, and to try to find out the common ground between the two specialties and try to start talking the same language. At the very beginning, it's basically impossible. But at the very end, you're going to start enjoying the journey. And when you see your engineers with a face that seems to be a little bit proud because you can understand 1% of what they say, they are more than happy.
Yeah, I love that. And I mean, there's so many analogies. I have a lab that focuses on testicular cancer and interface with a computational biologist. They're speaking one language, you're speaking one language, or you're trying to develop or identify new microRNAs to predict teratomas, for instance. And sometimes it takes a while to get there to the common ground. And not to sound cheeky, but the common ground is a better patient experience, no question about it. But when you start seeing the fruits of your labor, that this is actually moving the needle forward, I think it can be intensely powerful. And I think your collaborative spirit is spot on. I mean, it's challenging enough to be a physician or a surgeon, much less a surgeon scientist. Now to become an expert in all of these domains, which are so super complicated and people spend years educating themselves on. It's maybe digestible right now, but clearly in 5 to 7 years, it's going to be incomprehensible for us to work in isolation. We've kind of talked about the promise of AI and how it's just around the corner, and there are some maybe things that are a little bit closer than other. So as these come out, I think you've really been quite ahead of the game thinking about the responsible implementation, because any of us can kind of think about some crazy scenarios where big data, again, predicting personality disorders or predicting, a predilection for Parkinson's. And, we don't want to go back to like a eugenics type state of 100 years ago. And now it gets even more complicated, right? Large data sets being electronically transferred, ethical considerations, data privacy. How does this all work, Gio?
Well, that is an excellent point. Ethical considerations are extremely important, and they represent the very first step of the different layers that we have to consider when we are using or considering AI as a part of the game. Very recently, one scientist who is actually also an engineer and a priest in Italy, Paolo Benanti, who is a real authority on ethical consideration new technology, he coined the term algorithmics. Algorithmics is a mix between algorithms and ethics. And very recently I gave a lecture, and for the very first time I found myself putting those two terms together in the same presentation. Algorithm and ethics that, a few years ago was not even a thing. And just for making the point on how important it is, in 2020, the WHO, the World Healthcare Organization, put together a formal document statement that took 6 months of being produced on ethical consideration on AI. And there are 6 ethical considerations that has to be taken into consideration every time we are having, as I was saying, AI as part of the game in any healthcare activity. And one of the things that we have to consider is who or what is going to be accountable for the decision making. As doctors, every time we see a patient, we make one of our decisions based on the patient history, on the present history, present illness, or whatever. Everything is based on our knowledge. AI could potentially do the same with the same accuracy, but this type of technology is not accountable because it is just a machine. And therefore, here is the main problem, that this kind of technology should be always a part of the game, but only as an ally, as a copilot, not as a pilot. The real decision should be made by us as physicians. At the end of the day, one of the main critiques, that you can see, is like they always question, AI will replace physicians or AI will replace urologists. No, AI will never replace urologists. For sure, urologists who knows and start using or considering AI as part of the game will replace those who are not using or considering it. That is a different thing. And the second point, together with the accountability, is the explainability of those systems. Explainability is, a kind of weird word for basically saying how much a machine learning technology is explainable, how much this system is open, is not a black box. If I know that a system can go from A to B, but I can know in advance each one of the steps that are bringing the system to go from A to B, it will make me as a physician more comfortable to understand how the decision was made. The majority of the machine learning right now, machine learning technologies are totally black box. So we know the input, we know the output, but it's basically impossible to understand how these outputs were generated. There is a new type of technology that we developed here at the USC together with the Viterbi Institute. The name is green learning. And green learning is because first, we need less energy for having the same performance. That's why we call it green learning. Something that we need to consider also a carbon footprint of AI into our world. But most importantly, green learning is able to be an open system that allows to engineers, to doctors in our case, to go back and to understand how the system was able to go from A to B, how to generate the decision-making that the machine had done.
Yeah, a couple of comments. So one, it sounds like you better join them or get left behind. Robotic surgery, perfect example. I don't think everybody had to be an early adopter, but if you weren't going to be an adopter, then goodbye prostatectomies, partial nephrectomies. And I definitely appreciate that. And one other thing that kind of comes up in terms of ethical considerations, which is not exactly what we're talking about, are incorporating AI into academic output. Now, that's a small sliver of urologists and practitioners, et cetera. But I mean, the same time that I sat down for the first time with my colleague and he showed me ChatGPT, we also, just to kind of mess around, said, hey, can you please write a one-page grant with specific aims on a project regarding minimal residual disease detection of bladder cancer? And okay, it was somewhat generic, but it was also pretty darn good. How does this whole kind of aspect of the evolution of academic medicine get impacted by AI?
This is a very important point. As I was saying before, generative AI, even though it's generating something, is not generating something out of the blue. It's generating something because that system is exposed to a lot of informations, and then rewarding those information could potentially generate something. I remember that, when ChatGPT, was released, it was November 2023. And one of my fellows that came to the office, he's a foreign fellow, and he showed me the capability of those technology. And I start thinking, okay, we need to do something, because here the risk is that if this technology is going to be used by, you can use this technology in a good way for decreasing your workload. But on the other side, there is always the chance that people are going to start using it for, as you were mentioning, writing out of the blue papers or publications. And it's not only the writing of the manuscript, it's also the use of this technology, for example, in academia in general, in research. For example, there are some papers that mention that ChatGPT, generative AI, could potentially be used to find the gaps in the literature. Or ChatGPT can be used for generating hypotheses. ChatGPT can be used, for example, for do the analysis. Well, even though I'm extremely, supporting of new technology, we need to consider that this technology has to be supervised. And for this reason, in March, we started a global cross-specialty initiative. The name is Kangaroo. Kangaroo stands for ChatGPT, generative AI, and large language models for accountable user reporting. And we have created a real group of Avengers. We put together AI guidelines developers, together the Equator Network representatives, the COPE representatives, and the editors, section editors, editors-in-chief of the most important journals, from Nature to eLife to Lancet to Nature Machine Intelligence, Cell, and some others regulatory systems and agency, for putting together the first guidelines for the ethical use of generative AI in academia. One of the things that we are doing is to creating these 3 lists. The first is the don'ts list. So anything that you should avoid, for example, listing ChatGPT as one of the authors, or using ChatGPT to finding the gaps in the literature, or using ChatGPT for making a review of a paper. I can tell you that I hear the weirdest story about that. The second thing is that as long as you're following those don'ts criteria, so you're avoiding anything that is in the don'ts list, it means that you could potentially use it, and therefore you have to disclose it. As long as you're disclosing it and you're taking full responsibility of where and what you have used this technology, you're fine. And then the third list is how to report this technology. We need to, as I was mentioning before, talking about expert in generative AI is very reductive, because it's basically impossible to keep up with this technology and become an expert. And on top of this, we know how academia works. A paper is submitted, a paper is reviewed by your peers, and then it's going to be eventually accepted by the editors. The risk is that we don't have expert reviewers or editors that are expert enough to understand if the paper is good enough for being published. So therefore, what we are putting together is a framework that can assist authors, reviewers, publishers, and of course, readers and stakeholders to understand if all the important information are reported.
Okay. So I think that it kind of sounds like the intermediate category. It's like it's not high risk, it's not low risk. So it's got to be, those are your don'ts, and that's intermediate risk. And I mean, hats off to you, because it's a scoping project to try to capture all the considerations. And I've had a chance to read your review article, and it's quite enlightening, no question about it. So we've talked a little bit about things from the physician side. What is the responsibility and acceptance, in your opinion, from the patient side?
Oh, that's an excellent point. So in the majority of the cases, unfortunately, patients accept passively this kind of technology because sometimes they cannot understand the behind the scene. And therefore they say, okay, if my doctor is saying that it's good for me, I'm going to do that. And this is basically something that we have to consider also in the light of, the recent development for telemedicine. Before the pandemic, if you were asking to an average urological patient, like 65, 70, we're going to have a consultation by phone or by computer, nobody will say, I'm going to accept it right away. One of the only, maybe the only gift of pandemic is the digitalization of the population, especially the elder population. And therefore, because of this boost in digitalization, now the patients are accepting a little bit more, and they are more interested in what those technologies are. Again, we need to make sure that our patients are understanding that it's not going to be the AI that is going to take care of them. It's the AI that is co-piloting us for taking care better for their interest. It's like at the very beginning of robotics. A lot of patients were coming and say, hey, I want the robot to operate me. No, he's not going to be the robot. It's going to always me, but operating through the robot and, enhancing my surgical expertise. Again, I really believe that patients right now are more informed. They have more interest in understanding a little bit the behind the scene, but it's our duty as physicians to make sure that everything regarding AI is going to be used ethically, accountably, and most important, in a way that's going to be explainable to our patient.
Yeah, I appreciate that. And, one of my least favorite activities is at the end of a busy day to sit down and respond to 30 patient messages and queries. And boy, how delicious does it sound that you have a AI technology that can take all the patient messages that are ever been uploaded in Epic, team up with a automatic patient query responder. And hey, it's 3 days after my prostate, I've got a little blood in the urine. What do you think? Some poor resident in the middle of the night doesn't have to call them and say, stay hydrated, as long as it's no clots and continues to look Kool-Aid color, you're okay. But a Autobot responds to the patient. Is that good? Is that bad? I believe these are actually being piloted. What are your thoughts on that, Gio?
Well, is an excellent question. And this is something that we are trying to develop here. So one of the things about the chatbots, again, is the fact that the way that they reply, they are very human-like. And therefore, a patient could potentially ask questions and having some replies that sounds like a doctor on the behind the scene. I really believe that this kind of technology could potentially be very useful for a pre-triage. Imagine to have a patient, this patient underwent a TURBT, and the first question is that when they're going, to the bathroom, and they're gonna see some blood in the urine, they're gonna see some clots in the urine, very small, and they're gonna panicking. I mean, I could imagine myself in the same situation. So the first thing is that calling the doctor, sending messages, or sometimes go directly to the emergency department. And then, of course, it's going to be a cost for the society, but not only that, it's a human cost, because sometimes it's just, a matter of call and understanding that kind of stuff could potentially happen. So there are two things that we can use for, and can be used, those large language models. So from one side, as you were mentioning, creating these chatbots that could potentially go through the patient history, that particular patient history, and with proper training, understanding if that is a serious situation that requires an emergency department admission, or something that could potentially be managed, or is a normal healing process. On the other side, this kind of technology could potentially be used to bridge in the gap between our technical language to what a patient could understand. Here at the UC, we started the process, and it will be very soon a randomized trial, where we are going to have a GPT-4 creating layperson summaries of the discharge dispositions and discharge letters of patient underwent from TURBT to a radical cystectomy. And what we are trying to do is to make everything more understandable for patients. In a way, the first patient are not going directly on Google to get information, because we know Dr. Google is always around the corner. And sometimes we are just the second opinion and not even the first one. And on the other thing that we have to consider is that the more the patient are informed and the more they understand, the less actually could potentially be scared about the disease. I mean, I put myself in that particular thing. A couple of years ago, my girlfriend has leukemia, and I have to deal with, even though I'm a doctor, being on the other side and being a caregiver and trying to understand what an hematologist was trying to say to my girlfriend. And when you are on the other side, you are basically dealing with the personal impact that particular disease is having on your beloved one. And on the other side, the fact that even though you're a doctor, you don't understand everything. I mean, we are very specialized. And when an hematologist is talking to you about survival, about these things, about what could potentially happen, then the things are becoming totally different, totally difficult to understand. That's why I start thinking, okay, we need to deal with this in a way that somebody is not technically prepared for understanding that particular field. This technology could potentially help us, helping. And that's why we started this journey.
Well, thanks for sharing that personal story, Gio. And of course, we hope and pray that she's doing just perfectly fine.
She's doing good.
Yeah, I took it upon myself, at least for one of the more common diagnoses that I see, prostate cancer, to put together a video that's 30 minutes on newly diagnosed prostate cancer. And, we talk about Gleason scoring and PSAs and when imaging is required and surveillance, focal therapy, prostatectomy, radiation, et cetera. And when I diagnose somebody, the pathology comes back, I call them and say, hey, Mr. So-and-so, we did find prostate cancer in your biopsy. You're going to be fine. I want you to review these resources. This is your homework in the week before you come to see me. And then I find that our conversation is much more fruitful, much more practical, instead of they heard the word cancer and nothing else is kind of registering. And then for prostatectomy, I put together a video that I share through Well Prepped. It's on what to expect after prostatectomy. We talk about alternating Tylenol and ibuprofen and with your catheter care and scrotal swelling, incisions, bruising, blah, blah, blah. And that's dramatically reduced the impact. And I did have a patient view it before I published it to say, is this actually useful to you, interpretable to you? But I think you're absolutely right. There could be such a disconnect. If you started talking to me and said, hey, if it's generative AI, we're going to go this route. But if it's machine learning, we're going this route. If it's LLM, and just the acronyms, the verbiage, the lexicon can be quite overwhelming. So I think that's wonderful. And, again, making the patient experience as they're going through something requiring medical care better is, again, a main goal here. So I really appreciate you kind of walking through some practical examples, some of the ethical considerations, responsible utilization of this. Maybe we could talk a little bit about practical tips for exploring AI for a novice. Say actually, this happens to me where people say, hey, I'm interested in AI research. And I say, okay, I've got some ideas. And honestly, one time I told them there was a student from another institution. I said, you should try to connect with the folks at USC. I think they're kind of the leaders currently. But practical tips for exploring AI for a novice. How would you get started?
Okay, so there are several things that we have to consider. First thing first, that we know our education is in the majority of cases because we are physicians and is med school. And all this technicality could potentially not be helpful for understanding the real behind the scene of this kind of technology. So the first thing that we try putting together, we established this team of young passionates of new technology and AI that is powered by the Young Academic Urologists Working Group of the European Association of Urology. And one of the things that we are trying to do right now is putting together a free course where we are explaining in a already digested way, all the behind the scene on what is AI. That is the first step. So the understanding of the terminology and the possible application. The second thing that, in my opinion, people should start thinking is exploring. I mean, there are right now a lot of new publications And the way that, at least when I'm reviewing one of the publications, is always asking to the authors of rewarding the methodology in a way could potentially be explainable and eventually allowing reproducibility of their findings in a way that everybody could potentially understand. And the third thing is that our doors are always open. And if somebody wants to join the team and want to come here for doing a fellowship or research fellowship on artificial intelligence, we are more than happy to provide all the information and all the training that is needed for understanding what is needed at the very beginning to start your journey on AI in healthcare.
Yeah, I might have to apply if you're taking seasoned vets at this point. Gio, sounds pretty awesome. I appreciate that. And, for me, like I mentioned, as we kicked off, it was all fairly foreign. It seemed kind of abstract. And I actually just found kind of fooling around with ChatGPT to be pretty eye-opening and informative. And I think that could, maybe help. And I'm sure if you typed into ChatGPT, how would you advise a urology novice to get involved in AI research? It'd probably have some reasonable suggestions there. But I appreciate that. I mean, it's just like anything, right? Sometimes you got to jump in and kind of explore it for a little bit, learn about the methodology. It's like taking a course, right, on using a high capacity camera. You can read a textbook, but when you put the camera in your hands, you got to actually start taking some pictures and messing with the aperture and the zoom and the focus and see how it goes in your hand. I like that. And do you think that, are there actual instances today that are ready for prime time? I mean, is there like an example of something where I could start using this in my clinical practice tomorrow?
So that's something that we have to consider. Right now, the FDA has just approved, not for clinical, at least for clinical purposes, the use of AI-guided imaging technology, such as new software that could potentially be coupled with the Philips MRIs to automatically detect region of interest. And very soon they will come on the market. They will become part of our daily practice. And I'm pretty sure that you hear about the fact that some of the EMR, EHR softwares are going to partnering with Microsoft to basically start the journey of implementing large language models into the EMR. Right now, I would say that we are very close to having something that is going to help us in our daily practice. So I would say we are just begun, so back up to have fun.
Yeah, I sometimes just kind of wonder if it's not going to take some pandemic-esque event for things to go to prime time, whether it's an explosion of the global population where the physician shortage just got decimated. And now it's like time to kick this into gear and some things are going to slip through the cracks. Maybe an elderly person has a hard time or you can't get the images reviewed or you rely on a report. But hopefully not. Hopefully that whole experience has, as you mentioned, empowered us that, when push comes to shove, let's get that technology in there responsibly. Well, I love this. And I mean, it's amazing. And it's something that I think we're all proud of as a community to see urology on the forefront like we have been for so many technologies. Well, maybe as we come across an hour here, Gio, and I think I could pick your brain for another few, what are some kind of parting thoughts for the listenership on AI in medicine, AI in urology?
So I really believe that in general, when we are considering urology, we have always to consider that is a techno-driven specialty. We always been in forefront of embracing new technologies. I was saying from laser to robotic surgery to everything basically. So now AI could potentially be the perfect ally. It can be the perfect way for decreasing our workload, keeping the workflow, leverage everything to the highest performance as possible. And one of the things that we really want to, and I just want to stress it, is that we don't want to create any disparity, especially for patients. AI should be something that could ensure the inclusiveness in terms of how our patient could potentially get advantage of this technology. And as physicians, we have to be at the forefront for ensuring that. And in my opinion, be part of the discussion together with the engineers, together with the coders and computer developers and companies. And again, not be included in the discussion at the very end as users, but at the very beginning as developers.
I like that. That resonates. It's kind of like translational oncology. You can't just be the companies telling you what you need. We have to be involved in the part of the conversation. Well, Gio, it's been an absolute pleasure. Keep on pushing the field and rolling this amazing new, I think, disruptive technology. Well, new/not new disruptive technology out in a responsible way. Thanks again. It was an absolute pleasure.
Thank you. Thank you for having me here.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
And Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz, with support from
Devante Delbrun.
Social media and PR by G. Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.